Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Tim Quill. Today's episode features Dr. Ryan Gentzler from the University of Virginia in Charlottesville, Virginia, and Dr. Jonathan Riess from the University of California, Davis in Sacramento, California. They will be answering questions from a live meeting series on managing patients with EGFR-mutated non-small cell lung cancer, providing their practical insights on topics including identifying patients who may benefit the most from adjuvant osimertinib, testing for EGFR mutations in early-stage disease, and key ongoing trials testing strategies to improve outcomes for patients with advanced disease in both the newly diagnosed setting and after progression on current standard of care therapy with osimertinib. This episode is part of a larger educational program titled Expert Think Tank: Resources to Improve the Care of Patients with Non-Small Cell Lung Cancer and EGFR Mutations. For more information on the experts, along with a link to the complete program, including a downloadable slide set from the meeting series, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
Hi, my name is Ryan Gentzler. I'm a thoracic medical oncologist from the University of Virginia in Charlottesville, Virginia. Today we're doing the CCO Oncology podcast.
Hi, I'm Jonathan Riess. I'm a medical thoracic oncologist as well at UC Davis Comprehensive Cancer Center. Today we'll be answering audience questions from an ongoing live meeting series on EGFR-mutated non-small cell lung cancer. We'll start in the setting of early-stage non-small cell lung cancer and take it all the way through first-line metastatic treatment to what to do after progression after first-line therapy. Ryan, what do you think the ideal patient is for the use of adjuvant osimertinib based on data from the phase 3 ADAURA trial?
I would consider the ideal patient someone who had an adequate surgery for this disease with negative margins. Ideally, most of these patients would fall into the category of benefiting from adjuvant chemotherapy and would have received their adjuvant platinum doublet chemotherapy. But if you have that activating EGFR mutation and have those other two criteria in the appropriate stage, we see a dramatic improvement in disease-free survival from the addition of 3 years of osimertinib from this trial compared to observation alone. And I think that has clinically meaningful benefits for these patients. And I think even in the subgroups of the earlier stage disease patients enrolled in this trial, there seems to be a strong benefit there. So even in those 1B patients, I would think about osimertinib for these patients.
Yeah, those are some great points. And I just want to reiterate that osimertinib has a great disease-free survival benefit, most pronounced in the stage 3A, but also present in those stage 1B with 3 centimeter or larger tumors. Adjuvant osimertinib is not a substitute for adjuvant cisplatin-based chemotherapy in patients who are eligible and where it's appropriate, stage 2 resected 3A, for example, and so forth. And so I have those discussions with patients as well. There's a great DFS benefit, but an overall survival is trending in the right direction, but has not conclusively been shown an overall survival benefit. We really need those updated results.
I think it's important, depending on how your institution's set up and how your tumor boards work and the referral patterns, that surgeons or others are potentially aware that just because it's less than 4 centimeters doesn't mean they don't need to see a medical oncologist. So I think that's an important point of distinction. And I think, as you talked about DFS, certainly in a early stage curable setting, I think our gold standard is really improving overall survival. And we'll see what those data look like over the coming years. But I think the magnitude of benefit we see with the DFS here, certainly delaying progression, delaying symptoms related to metastatic disease, all have profound benefits for patients if you can push that all off 3 years at the very least.
And so Ryan, for considering the approval of adjuvant osimertinib based on the ADAURA data, what are you doing for mutation testing in early stage disease, locally advanced disease? Are you just doing EGFR, or are you doing broad genomic profiling like we do in the metastatic setting?
We have the luxury of being at an academic institution where we do in-house testing for NGS, and we've been doing this for 7-8 years now. And I'd say probably 5 or 6 years ago, we adopted sort of a strategy of doing reflex testing. So as soon as a biopsy is obtained and it's felt to be a lung adenocarcinoma, our pathologist will reflexively do our in-house NGS panel, which includes EGFR as well as other actionable targets. And I think in the beginning of this, when we implemented this, we debated, should we do it for only stage 4? Do we do it for all stages? I think from the pathologist standpoint, that's really hard to tease out sometimes if you're getting a lung biopsy without the clinical context. And we felt that it was useful information even before the ADAURA data, that when a patient progresses, you have that information ready to go and you don't have to pull tissue and do testing or repeat a biopsy necessarily. So we have been doing that. And I think having this ADAURA data available sort of reinforces what we have been doing, gives us early answers. And I think you could certainly make a case to only test for EGFR in this space, since that's the only actionable targeted therapy we have in early stage disease. But I would also argue that as we see new data and new approvals for neoadjuvant immunotherapy from the Checkmate H16 trial, for example, if you have an NGS panel and you're testing for mutations, you may want to incorporate that into your decision-making of applying immunotherapy, perhaps either in the neoadjuvant or adjuvant setting for these patients. So I think a broad-based testing panel has its merits, and certainly EGFR at the very least. And
so say we have a patient, they go on adjuvant osimertinib. Ryan, what do you suggest with regard to cardiac monitoring and so forth? What do you do?
I can tell you my clinical practice, I think baseline EKG on all patients to look at QTC, and then probably about 2 weeks after starting, recheck that EKG to make sure that you're not impacting the QTC negatively. And then I think the rest is sort of based on cardiac risk. I like to get a baseline echo and at least one 3 months later. For someone who's young and healthy and has no risk factors, I don't feel as strongly about that. The risk of cardiomyopathy is low, sort of 1% to 2%, if that. So I think you could tailor your strategy and how closely you monitor based on the risk factors. If you have an older patient, whether they have diagnosed CAD or not, it may be something that you want to monitor every 3 to 6 months with echocardiograms. But I'd be interested to hear what your thoughts and your practice is on this.
I follow a very similar approach. I'm more concerned in patients who are older, especially about the decreased ejection fraction. It's often reversible, at least somewhat. And so, as you mentioned, I'm more vigilant in elderly folks as opposed to younger folks with no kind of other comorbidities.
And I think the adjuvant setting is perhaps slightly different scenario. You're talking about a curative therapy, perhaps, and one where the patient may not have disease and may not need to be treated. So you can make a case for being a little more vigilant for monitoring this, because inducing a cardiomyopathy for someone who may be cured could be a much bigger deal. Whereas if you have someone with metastatic disease and they're benefiting from the drug and the EF drops 10 or 15%, it may be a little bit different risk tolerance there based on what's going on with the patient and the risk from the cancer itself.
What do you think the impact of neoadjuvant nivolumab plus platinum doublet chemotherapy, that Checkmate 816 regimen for resectable non-small cell lung cancer, what do you think that'll have on whether clinicians test for EGFR mutations in early stage disease?
I think both the Checkmate A16 trial as well as the ADAURA trial are really moving the needle on multidisciplinary team awareness on the importance of testing in general for biomarkers. Before either of these trials, it didn't really matter. You cut it out and you figure out the biomarkers after the surgery, and then you figure out what to do from the medical oncology perspective. But now we're starting to think about neoadjuvant approaches. We think about adjuvant targeted therapy, and we need to pay attention to these things. Both of these trials have raised awareness to that point outside of the medical oncology realm or stage 4 disease, where we've been routinely testing this for years. I think this approval will help in terms of getting more comprehensive testing on more patients and doing it earlier on. I think the challenge here is going to be logistics of who sees the patient first, who orders the testing, how quickly can you get those results? Do you need to wait for NGS testing or at least EGFR and ALK before implementing a neoadjuvant chemoimmunotherapy approach? I think certainly at our institutions where we're routinely doing this and probably sending it out fairly early, by the time you get your staging workup and PET scans and mediastinoscopies, if necessary, you probably have those NGS results. If you're in a community setting where everyone's in a different office and that patient comes to you later on and you're sending out and it's a 3 or 4 week turnaround, that can be perhaps a significant delay to wait for some of these, at least tissue-based tests. But certainly I think this is an opportunity also for plasma testing, maybe get results a little bit faster. There's debates about that. Certainly if it's a stage 1 or stage 2, early stage patient, what's your false negative rate with plasma? So I think long answer, but I think that we need to be testing. We need to test more routinely. And I think on a case-by-case basis, based on pace of disease, what workup they've had or not, whether you need, and certainly maybe incorporating clinical factors as to who you really need to wait before implementing a checkmate 16 strategy.
In terms of molecular testing in this setting, I once again do broad genomic profiling. I don't want to put an EGFR patient on checkmate 816, and the study excluded known EGFR mutations. And it always comes a question of, you don't have that, tumor in a bucket like you do in the adjuvant setting. And so you do plasma, you get a negative result. Is that a false negative, as you point out, because there's just not enough shed circulating tumor DNA in the blood because it's an earlier stage cancer? And you say you do tissue and the tissue comes back QNS, do you do another repeat biopsy before putting them on checkmate 816? How much do you delay things in a curative setting in that situation? What I've done is really kind of in those situations, patients who have a heavy smoking history where you kind of exhaust those initial possibilities, known EGFR excluded, you're following the trial, giving them chemo IO. Somebody who's younger, never smoking history, I think you're kind of obligated to dig deeper. That's my approach.
I agree with that. And I think it's one of those situations where you have a stage 2, T2N1, easily surgically resectable. Patient wants it out. Surgeon's ready to go to the OR next week, and your tissue testing just failed. It brings up issues with, is neoadjuvant going to be better than an adjuvant approach in a mutation negative patient? Do you wait? Do you go straight to surgery? I think there's a lot of questions there, and I think there's going to be a lot of debates about this at tumor boards. I don't know that we have a definitive right or wrong answer, but I think it probably emphasizes the point that all of these cases should be discussed prospectively at a multidisciplinary tumor board, and really weighing the risks and benefits of delaying treatment versus and getting that testing, the benefits of doing a neoadjuvant approach on a case-by-case basis. And I think some of the points that you brought up, Jonathan, are kind of dovetail well with some of the next questions that we've been asked here in the first-line metastatic setting. We have a question here about if you have a patient with stage 4 lung cancer, newly diagnosed, plasma was sent, and the testing is negative. You've done testing on the tissue, and let's say that comes back quantity not sufficient. You don't have adequate DNA extraction to do NGS on the tissue, and you have a negative plasma test. What do you do in that situation? Do you just move on and treat that patient and assume that they're negative based on the plasma? Do you delay treatment and repeat a biopsy? Be interested to hear your thoughts on that.
I usually get another biopsy. If you're QNS on tissue and it's negative on circulating tumor DNA. Now, if you find something like a KRAS mutation that tends to be mutually exclusive with an EGFR or ALK, feel like you've got something there. So if you detect something that's different than an actionable oncogene driver, that's one thing. But I think I usually, especially for younger patients, not a big smoking history, adenocarcinoma, I get another tissue biopsy. And so, I think it's important to know off the bat. There's data published now of enhanced, sensitivity of getting plasma and tissue. So I'm ordering both. One for the turnaround time. Plasma is so much quicker generally. Usually get it back in a week or so versus tissue. So I'm getting both on a lot of patients, particularly patients I think may have something, but also in patients with the smoking history. You never know. 7% of current smokers have EGFR activated mutations in published data. So that's my approach that I've been doing more and more.
Yeah, I totally agree with everything you said. Certainly, if you have that patient who's a negative, never smoker, young, try to get a good 2 biopsies, sometimes even a third, even if we're getting started with systemic treatment, if you're not convinced you got a good sample. The other strategy I would think about here is if you have someone who's got a heavy burden of disease, highly symptomatic, and your tissue just came back QNS, set them up for a biopsy and maybe chemo the day after you get that biopsy, but hold off on the immunotherapy and, make sure you've got a good tissue sample for NGS before starting them on immunotherapy. You can introduce it in cycle 2 if that good tissue biopsy truly does come back negative.
That's an important point because I think, you say you give IO with chemo and you find an EGFR mutation, published data rates of osimertinib causing pneumonitis after IO in that situation, 30 to 40%. So, you're kind of doing a disservice not to find those game-changing mutations.
Yeah, and not only that, but you limit their ability to get that drug indefinitely, right? If you get a pneumonitis with osimertinib, the package insert says to permanently discontinue, and so you take them off of a drug that could have given them a year and a half or longer progression-free survival. So, another question that's come up, how do we talk to our patients about waiting for results, especially if they really want that immunotherapy?
I say we want to find if we have a game-changing mutation that could really inform a different set of treatment options that are going to be more beneficial. And then the other thing I say is, you have an EGFR-ALK ROS1, immunotherapy is not going to do much for you. It may even be detrimental. And, what I often do too is I say, all right, we're going to get this other biopsy. I'm going to, if you feel worse, I'm putting in the chemo orders. We'll have an appointment set for you shortly after I expect to have the mutation in. So when you see me 2-3 weeks later to talk about the results, we're not starting this process over again. You're ready to go. You've got an appointment time. We could always change it if we find an EGFR-ALK ROS1. If it's no, then I'm set with a chemo date, and I could always call and start it sooner. And I've had patients that call and we talk about symptoms and decide whether to do chemo.
Yeah, I do the same thing. If you can ballpark when that result's going to come back and you schedule them a day or two after for chemo, go ahead and start the folic acid, a week before that date, and they're ready to go. And you can just put the brakes on it if you find a better option when those results come back. So I think those are good strategies. So here's an interesting question. Well, if you have a patient who ended up getting adjuvant osimertinib per the ADAURA trial for early stage disease and then developed stage 4 disease, they completed the 3 years or came off for some other reason, and there was a gap where they weren't on the osimertinib and then progressed, how would you approach that scenario?
So in full disclosure, I've not had that scenario yet where somebody's relapsed on adjuvant osimertinib, but I would get a biopsy to find out what the mechanism of resistance was. Start with plasma, then get tissue. Otherwise, you're looking at chemotherapy at that point. There's nothing else approved, in that setting. But it'll be interesting to see what the spectrum of mutations are in this setting.
Yeah, I think it's a different scenario. Someone who completes 3 years and hadn't progressed and then is off for a period of time. Obviously, no one's seen any of those patients yet, presumably. But if someone progresses while they're on osimertinib, then I think we're looking for resistance mechanisms, and we're talking about the same things we talk about for someone with stage 4 who's progressing. I certainly would think about re-challenging someone if they'd been off the drug for at least a couple of months, put them back on and measure the disease, see what happens. Would be a reasonable approach in that setting. Jonathan, you want to talk about any clinical trials that you're aware of going on in the first line space for EGFR mutant lung cancer?
I mean, we could always use further improvement. I mean, we're not curing these patients. There's 4th generation drugs are in development that get C797S, and so that'll be interesting to see how that works. There's 402, adding chemotherapy to osimertinib first line. Will that be helpful? There's an ECOG trial adding bevacizumab to osimertinib. I think anti-angiogenesis agents definitely add something, but we haven't necessarily as of yet seen the overall survival benefit that may support adding, an anti-angiogenesis agent to osimertinib. Or there's some interesting circulating tumor DNA approaches. So then to add on chemotherapy after basically checking ctDNA a few weeks into treatment with single agent osimertinib, and those we know from FLORA and other studies, SWOG 1403. Led by Sarah Goldberg, that that persistence or presence of circulating tumor DNA is a poor prognostic feature. It's kind of lack of benefit to osimertinib compared to PFS wise, compared to having clearance of your circulating tumor DNA. So adding on chemotherapy, using that as a selection biomarker, or other type of approaches in that situation, I think are an exciting avenue as well to really select out the patients who will progress early.
We've seen VEGF drugs with activity across the spectrum in non-small cell lung cancer, but a lot of those results have been fairly modest or not translated to overall survival. We've seen benefits by adding those in terms of PFS to first-line or first-generation EGFR drugs. There's a ramucirumab plus osimertinib trial as well being run by Dr. Lee through the Hoosier Cancer Research Network. I think, as you mentioned, the C797S drugs, we saw this with osimertinib, right? It was a T790M specific drug, thinking that when that resistance mechanism develops, that can be a useful agent. But if you move it to the first line, maybe prevent that T790M from emerging. Will we see the same thing with the C797S selective agents? All right. So assuming the patients are on osimertinib in the first line setting and develop progression, what if you have that stage 4 patient who is progressing on osimertinib? Let's assume you did some biopsies, did some testing, no clear targets. How are you treating those patients?
Yes. So, I mean, if there's right now nothing FDA approved for really targeted therapy post-progression on osimertinib. The standard treatment's chemotherapy, but I at least start with circulating tumor DNA and often do tissue biopsies in these patients to enumerate the mechanisms of resistance, see if you could target it. You can potentially do that with MET, RET, ALK, C797S, potentially go back to a first-gen drug like erlotinib or gefitinib. You can get small cell transformation too. The incidence of transformation is much higher in patients who have P53 RB1 mutations. So in those patients, I always get a tissue biopsy, rule out small cell transformation. But if I can't find anything, I'm looking at carboplatin pemetrexed. I sometimes add bevacizumab in bevacizumab eligible patients. I sometimes use Empower 150, but usually after platinum pemetrexed chemotherapy, and those in patients who are kind of hardier in terms of performance status wise, where I don't have a good actionable mechanism of resistance. And so Empower 150, they did show an EGFR in a subset analysis, pretty good response rate in PFS, but unclear if it improves overall survival. The numbers were underpowered there.
And I wanted to draw a little bit on the chemotherapy choice and immunotherapy choice. Certainly, platinum doublet plus immunotherapy is what we are using in patients without mutations. Is there a role for that in this setting? There's also been, some suggestions or movements to continuing the osimertinib and doing platinum doublet chemotherapy, perhaps particularly those with brain metastases. Do you do sort of all of these on a case-by-case basis? Do you not do the osimertinib continued?
That's a good point. I often do continue the osimertinib, particularly in patients with brain metastases, to help with that CNS penetration, especially if their progression is outside of the brain. So that's usually my standard in terms of the chemotherapy and continuing osimertinib. I don't do the Keynote 189 carboplatin pemetrexed pembrolizumab. Patients with EGFR mutations were specifically excluded from that study, and everything we know about PD-1 not being helpful in these patients.
I think there are a couple of clinical trials, sort of worth noting in this space with chemotherapy. There is a trial that I think is completed accrual. That's Keynote 789 trial that looked at exactly the 189 regimen in an EGFR patient population. We don't think that single agent immunotherapy works particularly well. For those that have EGFR mutations, does combining with chemotherapy change that or not? It'll be interesting to see that, just to confirm what I think many of us suspect. And then certainly there are other trials ongoing with chemotherapy right now. There's Mariposa 2, which is adding platinum doublet chemotherapy with amivantamab and lazertinib, perhaps a new agent that has shown some efficacy in the post-chemotherapy space, moving that up earlier in combination with chemotherapy. So I think we've gotten to this point where just giving a platinum doublet alone seems less appealing, but we just don't know exactly what the best add-on is going to be. I personally have not used the Empower 150 regimen a whole lot, just the toxicity profile with the taxane versus pemetrexed. hasn't swayed me to use that based on the results there.
Osimertinib is only for exon 19 and L858R, where it has an FDA approval. For the uncommon mutations, the third most common set is EGFR exon 20 insertions. And there's been a lot of exciting data over the past year or two targeting these uncommon mutations. Ryan, what do you do for first-line treatment before going through amivantamab and considering AMI or mobocertinib?
Before entering that real quick, I just want a point of clarification on uncommon mutations. I think this is important for people to recognize. There are a lot of different uncommon mutations, certainly exon 18 mutations and others. And I think it's really important that we don't lump all of those together as uncommon mutations with the EGFR exon 20. This is a specific mutation that's very different and perhaps less sensitive to second and third generation EGFR TKIs. And sometimes it's difficult to discern when we look at NGS reports. It may not say exon 20 insertion mutation. It may say something different, and it takes a little deciphering. So if you're in practice and trying to figure that out, it's important to know, is this an exon 20 mutation or not? But once you identify that mutation, what is the appropriate first-line treatment? We have a clinical trial that's looking at mobocertinib in the first-line space. And so if you have a trial, access to a trial certainly makes sense here. The two new agents that have been approved are in a post-platinum doublet chemotherapy setting. And so outside of a clinical trial, would still stick to platinum doublet chemotherapy for this group in the first-line setting.
The question that I get a lot is, there's some data that these folks may have a little more higher PD-L1 expression by and large for exon 20. Do you give pembro in these patients? I don't personally. I give carbopem or carbopem-bev.
I have not for the same reasons as you, but again, it's a data-free zone. The way I tend to think about mutations and the likelihood of response to immunotherapy comes back to smoking status. And I think that we've seen data that prevalence of smoking, can enrich for response to immunotherapy as well, or prior history of smoking. But most of these patients who are getting EGFR exon 20 insertion mutations are light or never smokers. Some of these agents have risks of pneumonitis or LFT elevations or other things. And we've seen, at least in lung cancer, that many of these TKIs don't play nicely with immunotherapy.
So now go to second one, Ryan. I'd just be curious, how do you choose between mobocertinib and amivantamab?
I think it's a tough choice. I think when you look at specifically at response rates, the amivantamab data a little bit higher on response rates than the mobocertinib. Mobocertinib's oral. It's not as well tolerated as drugs like osimertinib that target EGFR. I think there's more rash, more paronychia, GI symptoms, diarrhea specifically, that come along with mobocertinib. So even though it's oral, it's not necessarily an easy oral drug to take. Amivantamab has its challenges as well. It's an infusion with a high prevalence of infusion-related reactions. Because of that, the dosing of this the first dose is split between day 1 and day 2, and then it's a weekly for the first 4 weeks, and then becomes an every 2-week infusion. So I think there's logistical differences between these drugs, and that may vary patient to patient. If they're just have an early progression after getting platinum doublet chemotherapy and they're fatigued, and the thought of coming to the infusion center and dealing with potential reactions is an off-putting thing to them, maybe cycling to an oral drug and then switching back to amivantamab later may make sense if it's a good performance status and we really want to shoot for the best overall response rate in that second-line setting. Then I'd probably go to amivantamab.
Cross-trial comparisons always have their pitfalls, but as you mentioned, amivantamab, the response rate, and things where it was maybe slightly more numerically, they're basically in the same ballpark. Ryan, I just wanted to thank you. It was a great discussion.
Yeah, thanks, Jonathan. It's been great.
And wanted to thank CCO Oncology and wanted to thank our audience for joining us today for this discussion of frequently asked questions on the management of EGFR-positive non-small cell lung cancer.
Thank you very much, Dr. Gentzler and Dr. Riess, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, Expert Think Tank, Resources to Improve the Care of Patients with Non-Small Cell Lung Cancer and EGFR Mutations, and to download the slide set associated with this meeting series from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.